Hi, my name is Aaron Gerds. I'm the editor-in-chief of ASH Clinical News. We are here in sunny Orlando, Florida for the ASH annual meeting with our on-site coverage. It's a delight to be joined by Dr. Gabby Hobbs from Mass General, a world-renowned expert in MPNs. Thank you for joining me, Gabby.
It's my pleasure.
All right, so we know that there can be a lot of consequences of myelofibrosis and the other MPNs. We see, big spleens, lots of symptoms, transformation to more aggressive forms. We even know about the complications with cardiac disease and pulmonary artery hypertension. But little is known about kidney complications. This is a story that's kind of emerging. What's your sense in your clinic and what you've seen in the literature about the relationship between MPNs and kidney disease?
Yeah, so interesting. And I think that we really hadn't seen a lot of published work in this regard. And my sense in my clinic patients is that it's something that I know that my patients have, but I had never really known how to link it, associate it, or even think about, how their kidney function changes with response to therapy. So I think that this emerging story is really interesting.
Yeah, it is super interesting. I know there's been some really recent publications that note that maybe as high as 80% of patients with MPNs will have kidney disease. So probably a really important topic that's gone long ignored. So Dr. Rees, Brandy Rees, has really gone all in on this. Mm-hmm. She has some grant funding and really starting to look at these types of questions. In her abstract that she presented this year at the ASH annual meeting, she tried to unravel this story a little bit, maybe understand why. Were there any things that stood out in her presentation of why there might be an association between MPNs and kidney disease?
Well, her work was interesting. I mean, she had this murine model where she also demonstrated that mice with a JAK2 mutation, pathologically in their kidneys, they also seem to have the same some findings of renal dysfunction. And so she's really, like you said, going all in, trying to really understand how is this related, and it really does seem that there's something about the JAK2 MPN. I still don't think that we know necessarily what that is, but from the clinical data that she presented, looking at the REVEAL data, it does look like there's a group of patients that have, a decline in their GFR. These are patients that have a high LDH. These are patients that have higher risk disease by definition, that have maybe had a prior thrombotic event. So perhaps that starts to give us a feeling of, is there some microthrombosis happening in the kidneys, and that's why they're having an impact, but at least starting to see some predictors. And I think what's really interesting is that not only is having kidney disease detrimental because of just independently, but also maybe a marker of patients that have disease progression. Yeah. And I think that story is interesting and something that we really need to follow.
Yeah, I agree. As I see this emerge, I think back on my own clinic and yeah, I could really see there's potentially a relationship there. And we always talked about glomerular disease related to the MPNs, right? Thinking about the deposition of those proteins in the glomeruli, but there's probably more to that. There's probably tubular dysfunction. There's probably something else too. And I know Dr. Rees, a lot of the work she's looking at is looking at tissue factor as well, which will be interesting to see how that story unfolds. But a first look into this relationship, which I think is going to be really interesting.
Yeah, absolutely. And I think several questions come from this. Which is, do the therapies that we give patients make a difference? At least in her mouse models, maybe with interferon, there was an improvement in kidney function. Of course, the next question is, do we make a difference with any therapy? Do we make a difference with ruxolitinib, for example? And then I think that this also ties together to some of the work that we were discussing with cardiovascular outcomes, where we see that actually, patients that have pulmonary hypertension are also at increased risk of their ET or PV progressing to myelofibrosis. And this is a similar story. And so we see that there's many other areas that can have dysfunction that are predictors of progression. So I think that's also really interesting.
It really is. It reminds me of the old song, the knee bone is connected to the thigh bone, right? It's the same. All these things are interconnected. They're all really important. So,
and it's all inflammation.
Well, thank you for joining me today and sharing your insights into this really important abstract. You can read about this groundbreaking abstract here on all of our coverage, on-site coverage for ASH Clinical News.